Welcome to Partners for Advancing Health Equity, a podcast bringing together people working on the forefront of addressing issues of health justice. Here, we create a space for in-depth conversations about what it will take to create the conditions that allow all people to live their healthiest life possible.
Hello, and welcome to the Partners for Advancing Health Equity podcast. I'm your host, Karen Bell, Associate Director for Partners for Advancing Health Equity and Assistant Professor at the Tulane University School of Public Health and Tropical Medicine. I'm excited to introduce today's guest, Gabe Miller. Dr. Miller is an Assistant Professor of Sociology at the University of Alabama at Birmingham and Associate Director of the Deep South Initiative for Advancing Sexual and Gender Minority Health. His work focuses on political and policy determinants of health, population health, inequity, and intersectionality, and asks broad questions of community well-being and health. I wanted to ask, we give these introductions. This is your official titles and everything, but if you could describe in your own words your work and sort of who you are.
Yeah, for sure. So I'm a medical sociologist by training, and my research really centers kind of on the understanding that racism, homophobia, and transphobia diminish the health of people of color as well as LGBT people or sexual and gender minorities through lots of different mechanisms. So through structural mechanisms of inequity, through discrimination, through stigmatization, through minority stress as well. And as you mentioned, I really have kind of three main lines of research. So that first one, political and policy determinants of sexual and gender minority health, is a line of research where I really kind of investigate the effect that political and policy factors have on both aggregate health outcomes as well as individual health outcomes. That second line of work, which is really focused on population health, inequity, and intersectionality, I really focus and investigate how forms of inequity such as racism and homophobia can create these disparate population health outcomes and often intersect with one another, right? So racism and homophobia intersect to create disparate outcomes versus racism or homophobia acting alone. And then that third kind of line of work where I really look at broad questions of community well-being and health to try to understand in a better way how specific types of social support or social interactions really affect health.
So can you share a little bit about your work on race and immigrants and sort of how you got started doing that work?
Yeah, so I think the kind of the foundational training for how I approach this work really started in grad school when I read White Logic, White Methods. And in this book, they really take to task not only how social scientists have treated race as kind of a causal variable, but also has like how science broadly has treated race in a causal way. And so, because of that foundation, in all of the work that I do and that my collaborators and I do, we really try to frame our work as not relying on that white logic, white methods of suggesting that race is causal or that immigrant status is causal, right? That someone's race itself is causing the health outcomes that we observe. And so, for in one example of this work is the work that we've done with Black immigrants using the racial context hypothesis, which was created by Reed and Emerson in 2005. And kind of the crux of the argument of the racial context hypothesis argument is that the racial context of origin of Black immigrants is kind of the allowing us to better understand how racism as a mechanism is resulting in different patterns of health outcomes that we see among Black immigrants in the United States. And so the crux of the hypothesis argues that Black immigrants coming from predominantly white contexts of origin, so for example, Black immigrants from Europe, will have similar health outcomes as Black Americans born in the United States, which is also a predominantly white racial context of origin or racial context place. So, and then in comparison, Black immigrants coming from predominantly Black contexts of origin, so for example, countries in Africa should have the best health outcomes, and those coming from racially mixed contexts like the Caribbean or Mexico would be kind of in between.
You also do some work on race and sexual orientation and neighborhood and how they intersect. And just thinking about that type of work, could you share some findings that you have from that?
Yeah, so similar to what I just mentioned about the Black immigrant kind of paradox work that we've been doing, we take the same approach here, right? And don't suggest that race is causing health outcomes or that sexual orientation is causing these things, but instead we kind of conceptualize these things as categories that are markers that we use to identify people that are at risk for exposure to racism or homophobia or biphobia or the intersection of racism and homophobia. And so in one particular paper, we look at the association between neighborhood cohesion and psychological distress along race, ethnicity, and sexual orientation. And so we take a cross-categorization intersectionality approach, and we classify folks as for example, non-LGB white, LGB white, non-LGB black, LGB black, and so on, right? And so we're creating these categories that we then use as markers for exposure to racism or homophobia and their intersections, right? And what we find is that just using that as a predictor for psychological distress, for mental health, we see that people of color, and especially LGBT people of color, are at greater risk of meeting the criteria for severe psychological distress. But then when we throw in neighborhood cohesion, what we see is that the protective nature of neighborhood cohesion does not provide the same protections based on those classifications. And so I'd have to look up the article because I can't remember off the top of my head, but LGBT whites, I think, benefit the most from neighborhood cohesion compared to some of the other kind of cross categorizations of race and sexual orientation. And so again, we're again not suggesting that that race or sexual orientation itself is causing psychological distress. But we're adding in this piece on neighborhood cohesion to try to understand as kind of neighborhood cohesion as an intervention on psychological distress. Will it have the same outcome across groups? And what we see is that it doesn't.
Wow. I think that work is clearly important, but it demonstrates what you were saying as well, that really it's the exposure to racism and homophobia or biphobia that matters. Just like in your work on Black immigrants, it's the exposure to racism in a structural or systemic level, the way in which it's baked into societies. That's what matters for our health. Another thing that you do, which I really love, is work on social policy, and all of your work demonstrates how that is so important to our health. Could you describe how that work is different from a traditional public health approach to health? I think for me, what is coming up is that you're doing things differently. You're thinking differently about race and sexual orientation and even immigrant status. And I think you're also thinking differently about social policy. So can you talk about how your approach to this work is different than traditional public health?
Yeah. So I think just a quick background on on the work itself. So a lot of what I do in this area is looking at the effect that state level LGBT related policies have on again aggregate and individual health. And so state policy environment obviously doesn't happen in a vacuum and can range from like a very restrictive environment like Alabama, where I live, to a very protective environment like New York or California. And so what I've done is I've created kind of a measure of policy environment, of LGBT policy environment at the state level. And then I use that measure to predict various health outcomes. And so some of the work I've looked at aggregate HIV/AIDS outcomes at the state level. And so what I see is that, or what I find is that states that have more protective policy environments have better HIV/AIDS outcomes. So have lower incidence rates, have better kind of connection of care for people living with HIV/AIDS, have lower mortality rates, and so on. And so the policy environment, right, is what I'm conceptualizing as really a structural determinant here. And then, I've done some similar work with individual health outcomes, looking at how state level policy environment is associated with individual health, from different mental health outcomes to chronic conditions to cardiovascular health and so on. And so, I think the way that I've started to kind of conceptualize this work differently happened from a conversation that I was having with one of my mentors, where she called me an interventionist. And I was like, wait a minute, I don't do intervention research. Like, I'm not an interventionist. I'm not trained in that. Like, I don't know that I can call myself that. And she said, well, Gabe, all of the work that you do has like an intervention interpretation. Right. So if you think about, even the previous stuff that we were talking about with neighborhood cohesion, right? Neighborhood cohesion could be an intervention, right? Like, am I going into the communities and creating neighborhood cohesion in kind of the traditional like intervention way? No, but the research suggests that like that could be an intervention that might have an outcome. I think the same thing is true with the way that we think about policy and policy environment. And so policy, right, is a structural intervention in this regard, and it can be a protective intervention, and it can also be a non-protective intervention, right? So if we think about the massive amount of anti-LGBT pieces of legislation being introduced across the country, last year was a record-breaking year. This year is likely to beat last year's record-breaking situation, and so that is an intervention, right? Like, policy is acting as an intervention. It's having adverse effects on health if it's restrictive policy that's being introduced. If it's protective, then we would see it as a positive intervention. And so, I think part of why I had hesitation when she called me an interventionist is because I think in my mind, I think about interventions as being like individual focused or like community level or like individually driven, of like, we're gonna do an intervention to teach you how to eat better and exercise, and then you're not gonna have poor weight outcomes, right? And so I'm like, that's not what I do. Like, I also don't necessarily believe that that's effective, right? And so I've started to try to reframe the work that I do as having this kind of intervention tilt. Some of the work that I do on transgender health and community support and social support and family acceptance and rejection, I think has a similar, kind of a similar tilt, where we can think about support and rejection as interventions. And, the population health research that we're doing suggests that family support is a positive intervention, and family rejection would be an intervention having the opposite effect.
Right. Wow. I wonder, when you think about how you do this work, are you thinking about, okay, how can I make positive interventions, and how can I work to make these changes and change other people's minds about viewing this work in that way? Is that something that you consider?
Yeah, I mean, I think policy context matters a lot in how I would answer this question, right? So, when I'm talking with other folks in states that do not have the level of restrictions that Alabama and some of the other places that I've lived, Texas and Mississippi have had, they often say, how can you continue to do this work without becoming so depressed that you never have any wins or successes? And what I always push back on that, because one, there's a lot of trans joy happening in these places. There's a lot of resistance happening in these places. And I think, suggesting that we never have any successes in these contexts almost suggests that we just lay over to die, right? And that bad policy comes in and there's nothing that we do to prevent it from happening. And that is absolutely not the case. There's a very vibrant, community and folks are pushing back against, restrictive legislation. But that context matters, right? So for me in Alabama, an anti-LGBT piece of legislation failing in committee, right, or not getting past, the next vote, that is a success for me, right? Because that prevents the negative intervention from happening, right? Where, if we were in a state that is not introducing, restrictive policies, or if we were in the District of Columbia that added, LGBT topics to its, mandated curriculum last year, right? Like that, I think that's what people often think of as like a successful policy intervention. But that's not a realist policy intervention in the majority of the United States, because of the kind of the legislative landscape that we're seeing. And so I think for me, success looks different based on where we are or where we're talking about. And again, like these interventions don't happen in vacuums. And so it's, there's always more nuance, I think, than what we, want to believe there is.
Wow, that was that was really important to share, because I'm thinking about like how people who do work that is seeking to advance health equity can get discouraged, and like you just said, wins look different in different contexts. So that's really helpful for me, and I'm sure our listeners, to think about. Yeah, thank you for that. I'm wondering how you came to even thinking about social policy change, and particularly for LGBT populations. Like, where did all of that come from? Where did your desire to want to do this work come from?
Yeah, so I never thought that I was going to be a sociologist, much less a medical sociologist. So in undergrad, I was a political science major and had fully intended on going to law school. I was pursuing that path, had applied to law school, had planned on going to law school. And then, I like to tell people that I had a quarter life crisis my senior year of undergrad, which I maybe shouldn't call a quarter life crisis because then I'm not living as long as I would like to live. But it was basically a quarter life crisis where I'm like, I cannot do what I thought I could do with a law degree. And I don't know what to do. And so, that same year I was, was invited into a sociology graduate seminar at the same place that I did my undergrad, and was like largely introduced to sociology graduate school there, right? Like I already knew what sociology was because I was a minor in Africana studies. And so there were a lot of kind of sociology overlaps. And so I understood sociology, but I didn't really understand what grad school was. And so I got a taste of it there, and then ended up, applying and being admitted to a sociology PhD program, because of the quarter life crisis, right? And so, the thesis work that I did was largely kind of around, like more like whiteness studies, really had nothing to do with race. Sorry, it had a lot to do with race, didn't really have anything to do with health. And so, I was doing that work, but at the same time, I was a research assistant in the Race and Ethnic Studies Institute at Texas A&M. And the director of Resi was a medical sociologist. And so I was working with her on a lot of the health related projects and the health related kind of dissemination efforts that Resi was doing, and really started getting interested in health. And I think, because of that political science training background that I had and like the desire to go to law school, I always kind of in the back was thinking about, well, like politics matter in all these things that we're talking about, right? So like if we're just talking about racism and how racism operates, right? Like politics obviously matter and policy matter. And so the same, I was having the same thoughts with the work that we were doing in Resi about like, well, what about policy and politics? And so, at the same time, I started having conversations with other people in my life about essentially this piece, right, about how policy and politics matter to our health, and to kind of frame where we are in like the timeline. We're around the time when like Trump is running for office and for the first time and like campaigning, and so I was having these conversations with folks that essentially, I was saying the types of policies and, the political interventions that that you are voting for are killing people like me, as a queer person, right? Like they're literally killing me. And so I would always be countered with, you have no evidence for that. Like you're a researcher, like, but you have no research that shows that, right? And so I was like, I need evidence, like I have to prove these people wrong, right? And so that, that was one seed that was planted of kind of, shifting into this like policy determinants of health. And it's not to suggest that there was no research that had been done in this. There was a lot that had been done, right? But like it didn't exactly make the arguments that I was trying to make. And that same year, I had a person in my life that was a very central figure that died of complications to HIV/AIDS. So I was in a ballroom house, which is kind of a like a queer community and support building space. If you've watched like Pose or Paris is Burning, right? Like that's kind of ballroom culture. And so the father of my house ended up dying of complications to HIV/AIDS, and none of us in the house even knew that he was HIV positive. And so, I think I had a lot of like questions about like, how could this happen? Like, how can a person die of HIV given like the treatment that's available in this time, right? Like I was going through all those things, and then I was thinking about the policy context of where I was living at the time, which was Texas, right? And he was in Texas and he died in Texas, right? And so the switch that I made to my dissertation work, I think, was really motivated by those two things of like wanting to understand for myself, why Randall died, but also wanting to like have evidence to prove people wrong. And so the dissertation work that I did was essentially looking at how state level LGBT policy is associated with aggregate HIV/AIDS outcomes, right? So like very, very much me search, but was motivated for that reason. And so I none of that work has been published, and over the years, what I've started to think about is like, okay, those two motivations were really important motivations, but were maybe not the healthiest motivations, right? So like, I think in an odd way, I have this notion that like doing this research would prove all these people wrong and would like not bring Randall back, but would like give me an ability to better understand like, like why he died. And what I've realized over that time is that like some of the people that I most want to like provide evidence with that they are wrong are people that I think do not have the ability to change the way that they think. And there's nothing that I can do to like bring Randall back, right? But there are things that I can do to provide people that do have the capacity to change in their thinking, And there's things that I think that we can do that will provide, more protective environments or interventions that will prevent what happened to Randall from happening to other people. And so that I think has kind of how I've morphed, the motivation and the desire to do the work that I do, is to try to, equip stakeholders, policymakers, community organizations, right? Like all these people that have the ability to like make change and the capacity to, to comprehend, what we're talking about, right? With those tools to do that, to try to prevent, these things from happening in the future. So yeah.
First of all, I'm sorry for your loss. And, that's extremely heavy to have that experience, but it's also heavy to have your work be motivated by that. And I think that for many researchers and people who are doing this sort of health equity work, who are from marginalized backgrounds or identities, that the motivation is personal, is based on real experiences. So, thank you for sharing that and just talking about how you have worked to this point for change and understood these contexts. So yeah, that was heavy. That was heavy. Yeah. It made me think about your initial conversation though about white logic, white methods, actually. And how again, for people who have marginalized backgrounds or identities, that a lot of the work that they're doing is trying to prove their humanity, like you said. Or like white logic, white method says, a lot of the basic statistical approaches that we have, right, just regressions, right, were created by eugenicists. And so we're having to do all of this work just to prove that it's not something inherent about us. It's not a mistake that we made, right? It's not our behaviors or whatever. It's something outside of us that is causing these worse health outcomes, early mortality, stress, and mental health. So yeah, thank you for linking all of those things for me. Definitely.
Yeah. Well, I think you did the linkage of it. I mean, you're the one who connected it back. But yeah, I totally agree. I mean, if we think about like the foundation of white logic, white methods, right? It was to do the opposite, I think, of what many of us are trying to do, right? Like we're trying to prove our humanity. Well, white logic, white methods was the reverse, right? To suggest that we don't have so I mean, I think it makes sense, right, that like that the things are connected.
Yeah. Do you how do you continue to work with such a heavy, excuse me, let me rephrase that. How do you do the work that you do with such a heavy motivation? Is that something, are you still motivated by those same experiences, or have you had to shift your mindset? I just imagine that doing the work is difficult in itself.
I mean, yeah, I think it is. I also think that, the reality is that many of us are living in like literally a state of emergency, right? And so, I think there's a piece in the puzzle that I can play to try to address that state of emergency, right? Like I'm not a clinician. I cannot, perform heart surgery and save people in that way. But we also know that like things happen before people need heart surgery, right? And so are there things that as researchers, as academics, that we can do to try to prevent that from happening to begin with? And so, I mean, if we think about how racism gets under the skin, how homophobia gets under the skin, right? How all these things get under the skin and have a direct, impact in our physiological health that then result in all these things. I don't think that we can ignore the policy environment and the structural determinants of these things. And so, yeah, I think, I very much feel like a sense of obligation, I think is maybe the kind of the best description of it. I think, my motivations to like prove people wrong or to memorialize, Randall in some particular way are not this, like, I don't have those same motivations anymore. But I think my motivations today are built from those previous motivations, right? Like all these things are connected. And so, I think I think a sense of obligation is really the best way that I know how to kind of describe how I feel. Like I very much believe in team science. And so I think that makes this work manageable. right? Like if I was me, myself, and I by myself doing all this work, I don't think I would still be doing it, right? But I think because I take a, we take a team science approach and a largely transdisciplinary approach, like we form a community amongst ourselves so that we can support each other, right? So, if we're working on, I'm thinking about this one particular paper where my collaborators and I were looking at the association between state level policy as kind of a structural measure of homophobia, experiences of discrimination as more an interpersonal kind of experience of homophobia, and mental health outcomes. And what we find is that depending on the state level policy environment, those individual experiences of discrimination lose kind of significance in predicting the outcome. And so, we were working on this paper, and I was having a really bad day, and I was like depressed with some of the legislation that was coming out, and I was like, I can't do this. And so, one of my collaborators was like, you don't have the capacity to do it today, but I do. So I'll write that section instead of you writing it, and we'll keep it moving, right? And so I think having those people in my life, right, like in my professional orbit, allows us to continue doing the work that we do now. Of course, it requires us to be transparent about how we're feeling, right, and like how we're being affected by the work that we're doing and the larger kind of the larger context. But we've nurtured those relationships amongst each other so that when we are having one of those days, the other person can step in, right, and kind of take the lead. Or when we're doing like an R&R on a trans health paper, and there's folks that are trans identifying in the collaboration, in the collaborative group, and many times we get reviewer comments that are pretty transphobic and feel like a personal attack to like the trans person on the team, right? And so we just have like a kind of the way that we operate is the trans people on the team don't deal with those responses, the cis people do, right? So like as a cis person, like I address those things, and I'm doing it in collaboration with like the people with lived experience on the team, right? But we're, the same way that that with white logic, white methods and the approach that we take where we're talking about, we're saying that we conceptualize these things as markers of experiencing homophobia or being exposed to homophobia, right? Like that is that literally is happening in the science that we're doing, right? By nature of them being trans or being queer or whatever, that puts them at risk. That puts us at risk of having to deal with like these transphobic, homophobic, racist reviewer comments, right? And so having the team science approach where someone else can manage that so that the other person doesn't, I think it has been really, really important for my mental health and my well-being, and for us to be able to do the work that we've been able to do.
I think I'm gonna take away the need for community in doing this work. I think particularly if you are from or have a marginalized identity, but also I would imagine for anyone who is participating in this work, the need for community and to participate in a way that is supportive to others. Yeah. Wow. I think I'll also ask about, and maybe you're thinking about the role of community here too, but also thinking about advocacy. And I wonder if maybe just by nature of needing to address LGBT policy, you think of yourself as an advocate, but I'm wondering if you could share some of your ideas about approaches to advocacy.
Yeah, I mean, I think at the core, people who do the type of work that we're talking about, our work is read as advocacy first and research second, which is a problem, right? Yeah. And is rooted in white logic, white methods, right? Like your research is not real science, right? Like that's advocacy, right? Like we hear those things. And so, I think, so do I identify as an advocate myself? No, I don't think I would say that. but I largely think that I'm answering that way because advocacy has been weaponized against my science. And so I think I take a very strong stance of like, I am a scientist, I'm a researcher first. And like, this is the science. Like, of course, there are flaws, there are limitations in the science that we do, but like, this is the science. I'm going to turn it over for others to advocate with it how they might do, right? And sure, like I'm involved in advocacy efforts in different ways, right? But I think because our work is, advocacy is weaponized against our work, I don't identify with that, with the idea of being an advocate. And so, I think what this is bringing to light for me is like the personal reflection that comes into this, right? So like, I think we have to reflect on who we are, like what we're willing to do, like what our role is in the larger advocacy, world, and figure out where we best fit in, right? And so, if I think about, some of the work that I do and that my collaborators and I do, there are phenomenal community organizations that are doing great advocacy work. And so the way that I approach advocacy in that way is, I form collaborations and community with those organizations. And I really try to focus on like, what is it, like, what can I provide that you need? Rather than me saying, this is what I have and this is what you need to do, right? So like I really try to prioritize them taking the lead and them kind of directing like what are the empirical data points that they need to be able to do the work that they're trying to do, right? And so so I think that's one approach, is like forming connections with community organizations that are able to be like more in your face advocates, right? I think another approach is almost like not like a behind closed doors or back door approach, but like a more like a less in your face way, right? And so, some people take a different approach, right? And will be very vocal on social media, will be issuing statements, right? I think will be very visible with the things that they're doing. And I think that's effective. And I think that's useful in some contexts. I don't think it's effective or useful for me. I'm also, I'm on the tenure track. I'm an assistant professor, right? Like there's politics involved in this stuff. And so, so I think I'm very conscious of that. And so I think, doing this less like in your face, kind of direct advocacy work, is kind of not the avenue that I take. And so, so again, in having meetings with members of the legislature or policymakers or staffers, I think an approach is to take a kind of a similar approach to what I mentioned with the community organization, where like, you have things that you want to get across to the policymaker or to the staffer or the member of the legislature, but they also have needs, and you might be able to provide them with what their needs are, right? And so, I think it's very interaction based, right? And like relationship building based, right? I think if you go in guns blazing about like, this policy is going to be, is bad, you're the author of this bill, of this piece of legislation, and it's going to have this damaging effect, is maybe not, like that's an approach, sure, but I don't know that that's the most effective approach if you don't have a relationship with that person already. And so I think like building relationships in all the contexts that we're talking about is really important. And again, knowing that there are people who I think, in their personal reflection and figuring out where they best fit, like their role is to be like the protesters, the picketers, like the people that are very visible. And then I think there's other people who play a different role and serve a different role. And I think both of these things are needed. And so, I don't know that one is best or is better than the other. Like, I think I'm a very much like, all of these things need to be happening, and whatever is, what's effective will be effective. And of course, if we learn during the process that something is not effective, then let's quit doing it, right? So like if building these relationships with a particular staffer turns out to be like a not useful or a non-effective approach, cut your losses and move on, right? So I mean, I think like constantly kind of doing the reflection and thinking about like, what is the relationship that's being built? It can't be this one way, like, let me give you, or like tell you what I think you need to do. Because, you know, many of these folks like are coming up for reelection, right? And they have their constituents to speak to, right? And so so I think it's a game that, you know, that we have to play and have to think about.
Wow. I want to ask a follow-up question. What you said about it being a game and having to figure out what works and when it works, and having to reflect on that. I was thinking about when you were describing your research on LGBT legislation and how that's the measure of structural homophobia or biphobia. Also linking that back to your initial conversation about racist contexts of Black immigrants, whether they're from a predominantly Black country of origin or a predominantly white country of origin. Thinking about LGBT legislation and policies, or even anti-LGBT legislation and policies as the marker of structural homophobia, do you feel like the advocacy approaches, the approach, the game, the having to figure out what works differs based on the context, the level of homophobia in the context in which you're in?
Absolutely. Yeah. I mean, I think, you know, again, if we think about like, you know, Florida versus California, right? Like the way that, you know, the advocacy is approached is very different, right? So, you know, in one place we're trying to prevent, you know, or reverse bans on trans affirming care. In another place we're maybe trying to add, you know, like get rid of HIV criminalization, right? But there's not like active anti-LGBT legislation being introduced, right? And so I think like the context of the legislation is really important. I think the existing context of the state is really important. And so, you know, I with this, I keep thinking about Dog Whistle Politics, right? Which is this great book by Ian Haney Lopez that largely, you know, suggests that like many of these things are just like our talking points that particular people, like particular constituents, will hear the dog whistle and other people will not, right? And so, you know, I think the way that those dog whistles operate are different in different states and different contexts. And so, yeah, I mean, I think like if we came up with like a, you know, an approach that worked in Alabama or Mississippi and tried to pick it up and move it to New York or California, I don't know that it would work. Like you know, I really don't know. You know, I think what is probably standard across is like the relationship building and like understanding like what is it that you need that I can provide? What is it that I need that you can provide? Like I think that is consistent across contexts, but like, you know, we also can think about, you know, some states have lots of staffers in their legislatures, where other states are more volunteer based and there's no staffers, right? And so like you're literally going into like you would be going into a meeting with the member of legislature rather than like their director of policy, right? So like I think that the shorter answer of what I just said would be yes. I think it varies.
No, thank you for giving the longer answer. I also was thinking about how, you know, you identified as a researcher and how you work with community organizations and people who would identify themselves as an advocate. You know, at Tulane, our project, Partners for Advancing Health Equity, is a national collaborative that brings together different sectors such as academia, philanthropy, private sector, government, and community organizations to advance health equity. That being said, how do you feel your work should be understood and applied to other sectors like these that might not be thinking about health equity like you do?
Yeah, I mean, I think at the heart of health equity work is the need to be to be transdisciplinary. And I think if we are not bringing together different sectors, bringing different sectors together in the way that you just described, like I don't see how like health equity can actually be achieved, right? I think um, yeah, I think bringing them together has to happen. And so, largely because at the end of the day, there's only so much that, as an academic or a researcher that like I can actually do, right? Like I am not drafting legislation. I'm not writing, sure, I could write a policy white paper and get it into the hands of policymakers, right? But like that's not my job, my quote job at the end of the day. And I'm not like we're also not really trained in how to do that. Now, I mean, of course, there's great programs like Scholar Strategy Network that like train you and provide you with the resources to be able to do this. But that's not like how we're trained. That's not what we do at the end of the day. And I think the dissemination of our work is more powerful when it comes from those other players than when it comes from us, right? And so I think the dissemination of the work coming from a philanthropy or a community organization, I think carries a different weight than it does as coming from like me as the author of the work. Like the dissemination of it feels different to me. And so, I think meaningful work has to come from bringing everyone together. I mean, we keep talking about like team science and community and all of that, right? Like, I think we should expand the idea of team science to include these other people as well, right? So, we've talked a lot about state policy and like policymakers and so on, right? But like there are like private sectors, corporations also have policies in place, right, that are protective or not protective, right? And so I think the same conversations we're having about like state policy environment could be had with corporate, environment, right? Like, and so I mean, I think like private sectors have to buy in, right? Like if there's exemptions to things, like they have to buy in and institute policy on their own. Community organizations, I think, have boots on the ground in a different way than we do as academics, right? And so, I may think that like this one particular piece of legislation that's being introduced is like the most important, or it's the worst or the most important piece of legislation. But then community orgs, I think, have a better read on the pulse of like, is this a legitimate piece of legislation? Is it dog whistle legislation, or is it actually going to go through, right? And so I think if we don't have those relationships in place, we may go on a wild goose chase of doing some empirical data analysis on a transport ban piece of legislation, right? Like how do states with transport, banning trans kids from participating in sports, right? Like, does that affect their health? Well, it could very well be the case that like that's not a legitimate piece of legislation that is going to go through committee and go, be introduced, move through the process, right? But could just be something for the policymaker to say back to their constituents, like, I introduced this, right? How do I have no way of knowing that because I'm not boots on the ground in the state capitol in the way that community organizations are. And so I think forming the relationships is really central to being able to have kind of a real-time, rapid response to these things. I don't know if that completely answers what you're getting at, but yeah.
No, definitely. It definitely did. And I think that you gave a real life example of how we have to work together to advance health equity. It can't just be in our silos of research or philanthropy or even you mentioned the private sector. We all have to be advancing these efforts for everyone to be treated as equal. So yeah, thank you for that. And thank you for this conversation. Is there anything else that you would like to share or anything that you feel like we missed?
I don't think so, other than just like a thank you. I mean, I think the conversation that we've had is like really important and will be beneficial to the listeners. Has also been really helpful for me to like self-reflect on the things that we're talking about. So thank you. Yeah, thank you for having me.
Yeah, of course. We really appreciate it. We're honored to have you and just appreciate this conversation. I think that it's going to be very helpful to a lot of people. So thank you. And thank you to our listeners. We hope you found this engaging, and we look forward to hearing from you in the future. If you have any thoughts to add to the conversation, be sure to comment on our podcast episode page at Spreaker.com or on our social media channels. Thanks for listening.
Thank you for joining us this episode of Partners for Advancing Health Equity. Be sure to visit our website and become a member of our collaborative at partnersforhealthequity.org. That's partners, the number 4, healthequity.org. Follow us on Facebook, LinkedIn, and Twitter. And be sure to subscribe wherever you enjoy your podcasts. Partners for Advancing Health Equity is led by Tulane University School of Public Health and Tropical Medicine, is part of the Tulane Institute for Health Equity, and is supported by a grant from the Robert Wood Johnson Foundation. Until next time.